Dr. Nalini Patha. Nalini is a medical professor at the University of New South Wales, and she's also a member of the Gospel Society and Culture Committee. Welcome, Nalini.
Hi, Amy. Thank you.
Given that we've all been in various forms of lockdown in New South Wales, have you found any opportunities to pursue a new interest?
Not really a new interest, but I took up painting again after a long time, which is great actually, to relax a bit.
That's so good. Well, I'll hand over to you now, Nalini. Thank you.
Thank you. I'm going to share my screen again, so just give me a second. Is that good?
Yes.
Perfect. So thank you everyone for coming to listen to this talk. And today I really want to just give you a bit of a summary of where we are in terms of health. And perhaps first starting with the idea that we're actually dealing with a different virus strain. We're dealing with the Delta variant, which is quite different from the other variants that we've dealt with before. So some of the things to understand when we're talking about the Delta variant is that it is different from other strains. It's perhaps, if you can think about it as comparing apples and oranges, that's exactly what we're doing when we're talking about Delta compared to the other variants. Some of the things to understand in terms of it is, of course, the variant is different, but also our circumstances is quite different from when we were looking at the other strains last year. For one, last year we didn't have vaccination, or earlier this year, and also we didn't have drugs that could help us treat people who had COVID. So some of the things to actually think about when we're talking about a different variant like Delta is lots of the data that we have or that you have access to is not as relevant to this strain. And you'll see that lots of the data that I actually reference in this talk is data that's emerging. It's very much papers that are still going under peer review because it still needs to be vetted, but they're out there because the information is really important and valid for us to have now. So some of the things to think about why Delta is different. Obviously, it looks different, which is why it is being labeled with a different variant. And if you look at it, you'll see that it has a number of spikes on its surface that is different, which means that it attaches onto the cells in our body in a different way. But besides actually looking different, it also behaves differently. It behaves differently in terms of how it's transmitted to us, how easily it can actually take hold of our cells, but also it's different in terms of how much of it we carry around with us to other people. So we talk about a number of different terms, and I'm hoping that this evening I'll give you a quick rundown of what those terms mean and how they relate to the Delta variant. So there's things like viral load, and it has a higher viral load. It's more transmittable, and it has a shorter incubation period, which makes all of those things dangerous to us because it increases the morbidity and the mortality when we deal with COVID. I know the last time I spoke to everyone, we spoke about herd immunity, and I think it's good for us to just remind ourselves about what that herd immunity is. So if we look at the first set of circles that I have, the first square of circles, that sounds odd, the first lot of circles in blue and cream, let's talk about that first. So this is what it looks like to have a population that has no immunity to a virus. We have a number of people that are healthy, but they're not immune. And then we have a number of people that are vulnerable, just normally in the population, like how we normally go to it. And then when someone gets infected, that infection is transmitted from one person to the next. And the way in which it will get to a vulnerable person is much faster in a population that has no immunity. If we do take a vaccine or gain immunity in other ways, we become the green circles on your right. And so we're protected. And because we're protected, it means when one of us gets infected, it's very difficult for that infection to be transported to our vulnerable people. And that's really what we're talking about when we're talking about vaccines. Firstly, it protects us, but then it also protects those people who are vulnerable. Now, I said Delta is quite different from the other variants. And one way to just illustrate that here is when we talk about the rate of spread, or the RO number that we often see. When we were talking about the alpha strain last year and the beginning of this year, we were talking about a transmittability that was about 2 to 3 in terms of the numbers that we give it. Now that we're talking about Delta, we're actually talking about something that is 6 to 7 in terms of a score, but the new evidence is actually suggesting it's much higher than this, that it's more likely to be 9. The really good news for us is that we've had such great uptake of the vaccines in New South Wales. And this is, I think, the data from 2 days ago that I've put up here. And you can see that New South Wales and ACT is probably leading in terms of the number of vaccines. And if we just look at last week, the number of people between 12 to 15 years who took up the first jab was probably the fastest uptake ever recorded in terms of vaccines. There's lots of predictions about when we will get to 80, and my colleagues and I, we've predicted this, and with our predictions, it is on the 21st of October. So we're not far from that 80% mark. Now, I know people have lots and lots of questions when we talk about vaccines and we talk about this virus. So I thought what I would do with the rest of this presentation is go through some questions that are often asked and some of the explanations about it. So the first thing I thought we could talk about was, what is viral load and what is viral transmission? So when we talk about viral load, what we're actually talking about is how many virus particles you have in your body, and you carry that around with you as you go, and that's how we transmit the virus. So Delta is more transmittable, and it's more transmittable for a number of reasons, because it infects people, obviously, but it infects people who are vaccinated as well as the people who are not vaccinated. So like I said, lots of the data that I'm quoting here is still going under peer review, but it is data that is relevant to the Delta virus, which is the data that's been emerging since July this year. It is estimated that the viral load, that's the amount of the virus we carry around with us, is about 1,000 times more in Delta than it is in Alpha, or first original strain. We also know that it divides and multiplies itself faster. So it multiplies and is able to infect people, or you become contagious with it, so you can spread it by 4 days, whereas with the earlier strain, it was 6 days. So there was a much more shorter period for when you become contagious. And the trick and the issue with that is really, because it's such a short period, when you start transmitting it to other people, it means that it is a shorter time for someone to identify that you have the virus, and then to do things like contact tracing and isolating and all of those kind of things. So it makes this much more easier to transmit for all of those kind of things. And of course, for us, because the number of people that are getting infected is much higher, it means that we don't have the capacity to do contact tracing like we ideally need to do in this situation. So the challenge is that we end up with events that are called super spreading events. And these are generally events that are going to be in prolonged indoor gatherings. And generally, because this is a virus that is promulgated by the air, it is in places that have poor ventilation. And ventilation and air quality is going to be something that we hear about a lot as we go forward. So I suppose the end story that I want you to take from this slide is that Delta is really difficult to stop once it gets hold of a community. Now, people often ask whether Delta can be spread in vaccinated people. I think I alluded already that it can, but let me just explain it a little bit more. So unlike the other strains, more than any, this Delta variant can actually be transmitted via vaccinated people. Vaccines are obviously great, and they are our first line of defense. And I'll show you just now data that shows that it actually protects us against serious illness and death. In Australia, our standard regime is 2 doses of mRNA vaccines, and that is probably about 90 to 95% protective for us. Of course, I said that vaccinated people can actually transmit this virus, and they can actually get sick with this virus as well. And so that portion of people, even if we were fully vaccinated, are the portion of people that could result in hotspots. So hotspots is a concern, even as we get more and more vaccinated. Some of the data that is emerging about vaccinated people is that they are infectious for a much shorter time, and that's a study that came out of Singapore. They also carry a slightly lower load, that viral load that I was talking about earlier. than unvaccinated people. And that's a study that came out of the UK. And the days from exposure to infection is shorter. So that's good as well. What we don't know about this variant still, even with all these studies that are emerging, is just how infectious it is and just how infectious it is to vaccinated people. We also don't know how long we walk around and are able to transmit it. There's lots of things that we can try and figure out from the previous strains, but we don't know about Delta, and Delta is hard to actually pin down for some of these things. And like I said before, our biggest threat right now is that we aren't able to do contact tracing in order to actually isolate people who are contagious. And for this reason, personal protective wear and measures are still important. So things like mask wearing, hand washing, social distancing is really, really important. So even at this stage, you should not think about getting into a small contained space with someone who is older and maybe more vulnerable in the population. So some real concerns about this variant. I mentioned things like hotspots, and so I just wanted to explain what breakthrough infections are so that we are on the same page. So when we talk about breakthrough infections, we're actually talking about fully vaccinated people who become infected. And when they become infected, they can obviously transmit the virus, but they can also develop COVID-19. COVID-19 is the disease we get from the virus. And when they develop the disease, they can transmit it to other people. So like I said before, this is the problem that we will face, and this is the problem that will create these hotspots. And these hotspots may mean that different places or different communities have to go into more restricted regulations. Of course, where there are hotspots is going to depend on where you live. And it's also going to depend on how many people in your community have been vaccinated. The more that are not vaccinated, the more likely that it will spread faster and become a hotspot. And of course, the other thing that's going to be really important is whether we've taken all reasonable precautions to prevent the breakthroughs from happening and the hotspots from developing. So in the short term, and when I say short term, probably from now till the second half of next year, we're going to need a very multifaceted approach. COVID is not disappearing. Even if we get to 90%, we're still going to have to deal with it. Vaccines are not enough. We're still going to need to do things like contact tracing, testing and isolating. And really, we're going to have to focus in a really big way about how we ensure we're in well-ventilated places. And like I said before, this idea of clean air is going to become very, very topical. So the thing to take from this is that we have to develop comfort with living with uncertainty because it will be here for a little while longer. And we also have to be flexible and adaptable as we have been in the last year and a bit. Another question that I often get is how effective are the vaccines? I did allude to the vaccine being effective, but I want to give you some more evidence for that. So when we talk about efficacy of the virus, it is a term that is often used and not quite understood. So when we say a vaccine is 80% effective, many people think we're actually saying that the vaccine will work 80% of the time. That's actually a misconception. It's not that the vaccine will work 80% of the time. What we're actually saying is in a vaccinated group of people, you know, like when you saw before, if we looked at all those green squares, among those green squares, 80% fewer people will contract the disease. So that's a big thing when we think about how we can actually contract the disease and how we can transfer it to other people. So let's talk about that effectiveness of the vaccines. Vaccines, I don't think there's any vaccine that is 100% effective. So there's no vaccine that's 100% effective. These vaccines though, these two mRNA vaccines that we have, and now the third one, they're actually 90 to 95% effective. Now, when I say that, just bear in mind that that efficacy that I'm talking about is probably related to alpha. And so we need to be thinking about this in terms of delta. So how can we actually think about this in terms of delta? There is a number of studies that have emerged. They're still under peer review, so the data is still being checked and authenticated by other researchers in other places. But there is definitely shows that there's substantial effectiveness for the original strain and for the alpha strain, to the point where it prevents severe complications in people. In about 92% of people will get sick, and it prevents death in about 83% of people that get sick. There's very strong evidence from this data, and the newer studies that have now come through, and I've put lots of reference on the slides, which hopefully you'll get afterwards, is that this effectiveness actually extends to the Delta variant. So we do get that same kind of efficacy. One of the things that is really interesting is that it also shows that if you had the disease before and you take the vaccine, you actually are more protected than when you don't. So lots of questions, I imagine, about boosters and whether we do need boosters, and that's an important question. Now, one thing that I want to actually explain when we talk about effectiveness of a vaccine, it's not a constant number. So when I say 90 to 95% effective now, it's not that forever, because effectiveness is actually quite a big, complicated science behind it. Everything changes, our circumstances change, the virus changes. And so when we talk about that number of effectiveness, it's actually a dynamic number. The data is actually more complex than people think, and it needs careful interpretation. So it's not a good idea to take one paper and to decide on the effectiveness of one paper. I put together some of the factors that goes into assessing effectiveness of vaccines so that you can get your mind around what are the different things to be looking for. So some of the things we're looking for is the actual person who's getting infected and how their body is, looking for things like their other diseases and their age. We're also looking for a range of other factors like immunity and demographics of the local community that is where the virus is, but we're also looking at things like human behavior. How do people behave in their communities, and how much of immunity does that community actually have? So all of those things go into calculating how effective a vaccine may be. And of course, those things are pluses and negatives, so there's lots of interpretation there. And this is probably where lots of misinformation and misconceptions come, because the whole picture isn't quite understood in the same way. So talking about effectiveness of vaccines naturally leads to talking about boosters, and there is lots of conversations about boosters. This is my take on the boosters. I think boosters are a moral issue, and I think it's a moral issue because if you look at that first graph that I put there of vaccination rates in every country, in every continent, you'll see that some continents like Africa are vastly below in terms of vaccination rates. And that's not because of hesitancy, that's because they just don't have access. If we look at our near neighbors, Papua New Guinea has 1.3% of its population that is vaccinated. Earlier, when vaccines first came out, COVAX was set up, and the idea of COVAX was that the wealthier countries will subsidize the vaccines for the less well equipped countries. And we know that what's happened in the last 6 months in particular is many of those vaccines that were intended for the low-income countries got deviated to other countries like ours as well. And so this idea of vaccine nationalism and vaccine hoarding is something that is a real problem. And you may wonder, why is it a problem for me in Australia? Well, it's a problem for us in Australia because no one is safe until everyone is safe. And the reason for that is, as long as people still are able to get the virus and get sick in large numbers, then we are still prone to having new variants come and create another set of issues for us that we will have to deal with as well. So besides wanting to help people who aren't able to get the vaccine, it's also good for us to help them. So this question about the third dose and boosters, I just want to explain the difference between a third dose and a booster. Now, lots of people, when I say lots, it's not huge numbers, but a significant number of people actually do need a third dose. And they need a third dose because their immunity is probably less, or the effectiveness of the vaccine in them decreases over time. So they need a booster to keep their immunity up to the same level of the rest of us who don't have other health issues. That's different from a booster. And so a booster is, for example, the boosters that will roll out next year in Australia. And that is to give us, all of us, a third dose so that we can keep our immunity going. Now, the reason why I say this is controversial is because the best evidence that is still emerging says that from what happened in Israel, we know that the third dose is protective for people who are older, but both these studies came out last week, but The second study, which is a really large multinational study across 5 countries, actually says that we don't need a booster if we're under 60 years. So all of these things we need to think about, and we need to adapt and change as new information comes through. Now, one bit of data that we don't know and we don't understand when we talk about boosters is this idea of age and comorbidity. And those things have to be taken into consideration as we think about this third booster dose that we may need. So one of the things that we do need is some transparency about how these decisions are made, even here in Australia when we talk about boosters. So you may also be wondering, who are the vulnerable people when we talk about vaccines and COVID? Well, the vulnerable people are hard to actually identify because they look like you and they look like me, and they likely are you and me. There are people who are immunocompromised for a whole range of reasons. There are also people who are undiagnosed with other medical conditions, or may also be diagnosed and have other medical conditions. There may be people who have allergies to the ingredients that go into the vaccine. So the vaccine has obviously the active ingredients, but a whole lot of other things that go into it to make sure that it gets to the right cells in your body. And so some of those people do have allergies too. Other people who are vulnerable are people who are families and carers of all these people who cannot take the vaccine. And of course, for our children, especially those under 12, they are vulnerable because they don't have a vaccine. And remember that with Delta, I should have said this earlier, it is actually, the children seem to be getting more sick with Delta than older people has previous with the other strains. Now, people also talk a lot about Israel and what happened in Israel in terms of COVID. So I thought I'd just explain this case history a little bit so that we can contextualize it. So in terms of Israel and what happened there, remember Israel, the graph on the right, I think it's right, in green, that is the data for Israel that we're having a look at. So Israel reopened in their summer. They were doing really well. They had a rapid vaccine rollout. By March of this year, they had 50% of their people vaccinated, which was a really good number at that time, probably one of the highest in the world at that time. But we know that this month that they have had huge number of cases, even though we have 68% of their population that is vaccinated. So they still have an issue. There's lots of speculation as to why they are in this situation, and hard to really tell until we have more data. In some ways, we may not even be able to tell. There's questions about the vaccine coverage and whether there is hesitancy. We know that there was definitely in the under 20-year-old population. There's also questions about community transmission and Delta variant there. But one of the really interesting things or important things to pick out of Israel's case was that vaccinated people were susceptible to getting sick. They were the people in the hospital, and people who were elderly and had comorbidities were the people who were getting sick even when they were vaccinated. I said it's hard to actually understand what's happening in Israel, and that's partly because although it's a whole nation, it's still a very small data set when we think about the numbers of COVID cases and the number of people that we're talking about. There's also strong evidence that in Israel, it was people from higher socioeconomic sectors that were vaccinated more than those from lower. And there's also other things to consider, like whether the testing was all the same and whether people had built up natural immunity. Now, I think that natural immunity thing is something that I'll just speak about very briefly here. So one of the other challenges for us in Australia is that we are a population that hasn't built this immunity because we've not been exposed to the virus. So our bodies are still quite naive to the virus. So one of the things that we can take from Israel and why there is some cause for caution is that we would actually need a very much more staggered and flexible approach when we think about how we come out of this lockdown. So I thought this would be a nice place to actually talk about where we're heading in terms of this. And a few things to take note when we talk about where we're heading. And like I alluded to just now, Australia and New Zealand actually has no parallels in the world. We are quite different from everyone because we have very peculiar circumstances in terms of how we've managed and how we've managed the virus and how we've been very successful in that way. One of the great successes out of New South Wales actually is that we did an incredible thing. When there was a large Delta outbreak, we actually dropped our case numbers quite significantly. And of course, like I said before, we have this really high uptake of vaccination and at a really fast rate. But for us, as we all know, the challenge is how are we going to open or reopen safely? And some of those challenges is inevitably when we reopen, we are going to have people that are more sick. We are going to have people that die, and we are going to have people that are hospitalized. And they will be people that we know and we care about in our churches and in our families. Lots of people compare us to UK and the US, but that really is not a good thing because we are not a comparison to them. Possibly, if I could think of a country for us to compare ourselves with, we're more closer to Denmark than to any of the other countries. And so that's one of the case studies that is being looked at quite nicely for working out where we should go. I think the other thing to bear in mind when we think about our data and our stats, when we say 70 and 80% of people are vaccinated, we're talking about that population that is greater than 16 years old. So in true fact, it's like 56% of our population that is actually vaccinated and protected. And remember that I said with Delta, younger people and children are vulnerable in that group. A really good question to ask is, and people ask this all the time, is what is the increased risk if vaccinated and unvaccinated people are allowed to mingle closely in gatherings? And I think to answer that question, one of the things we need to understand is how all of this modeling is done and how do we make decisions about what needs to happen. So modeling is modeling, right? So it's always based on assumptions and predictions. And some of those assumptions and predictions that we're basing modeling on is the effectiveness of our vaccines and how often or how frequently we're going to have transmission. And then we're also thinking about things like all of those 4 stages of lockdown and what's going to happen and how people are going to behave. So obviously, if you read those things on the slide, you realize that it's very uncertain. Everything that the predictions are based on is assumptions, and there's lots of things that can go wrong with these assumptions. So I've put up these graphs, and don't worry about trying to understand it. I'll walk you through what you need to understand. These graphs are modeling from 2 different places. The first one is from the population unit in Melbourne, and the other one is from the Doherty. So modeling can be done by different people. And when different groups of people do it, the assumptions are slightly different. And then if you look at those 2 graphs under Doherty, even when it's the same people do it, the assumptions can be different. And so for that particular graph, you'll see one of the assumptions is that we'll be able to be really good at testing, tracing, and isolation. And the other, the last one, is that we will be partially good. We won't be as good at doing that. And all of those things go into determining how this virus may act and how our behavior may act. So in purple, I've boxed all the graphs that are colored because those are the graphs or the lines that are actually telling us, in terms of those 4 lockdowns and the predictions about how people will behave, how the virus will be transmitted in our communities and how much of infection we have. So that's part of the reason why there is some certainty to say, okay, we can come out of lockdown at 80%, probably better if we have better immunity. If we let both vaccinated and unvaccinated people out at the same time and allow free mingling, the line that we're going to follow is the line that is dotted on top with the red arrows pointing to it. So there's a significant difference from letting vaccinated people out first and then unvaccinated. That's not to say that we shouldn't have everyone out in the community. It's more about, like I said before, the staggered slow release so that we can adjust and control and also make sure that more people can be safe as we do this. Now, of course, with all modeling, it needs real world effect. And what's going to happen is as the first set of regulations relieve, there's going to be lots of remodeling and relooking at this and optimizing and changing, and also changing the way the restrictions are going to work. And lots of that will have to be done at a local level. So when decisions are made, it has consequences for individuals and it has consequences for whole groups of people. And so when we look at these kinds of decisions, the thing that we have to take into consideration is all the different kinds of people and how this will affect them. But we're also taking into consideration things like how this virus is transmitted. It's transmitted in cold, dry, crowded places, in close contact, in confined places with poor ventilation. So they all go into the equation to try and work out what's the best solutions. And the best solutions for us as different communities will be to start thinking about what are those practical ways in which we can take care of all of those different kinds of people. Some of the things that will be with us is how we mitigate risk of spread, and that's looking at things like masks and ventilation, but also other kinds of things that we need to be thinking about is, for example, lives at risk versus life expectancy at risk. So for us in Australia, that's a big thing because COVID not only makes us sick acutely, it gives us long COVID, which means we have long-term effects, and that decreases life expectancy. Whatever we do, we're going to have to do it in a trustable, transparent way where we consult with lots of people. And part of the difficulty in this is trying to work out what different people's thresholds for suffering are and what they consider suffering. So lots of things to think about as we think about this data. Another aspect that we should be thinking about is this idea of going to an endemic state, because that is where we're traveling. The road we're going on is to get us to a state where we are in an endemic. So how do we go from a pandemic to an endemic? And I thought that would be something that's interesting to talk to us about very quickly. So endemic really means that the virus becomes a normal virus in our society and our community, and spread is normal spread through population. So if you think about us in Australia, we have an endemic virus. The Ross River virus is endemic to Australia. You won't find it in most other places. And when we look at the world at large, we also have an endemic virus, and that's the rhinovirus, which comes annually as the flu. So we do have endemic viruses. When we have an epidemic, it means that there is a smaller group of people, usually a community, that has widespread infection. And so when we think about epidemics, we think about viruses like Ebola in different places of Africa. So really the key here is for us to be protected, and the best tool for us that we have right now for protection is vaccination. We need an uptake of about 90% to come to herd immunity where we can go to endemic, and hopefully that's going to happen in the next few months. But there will always be those people who can't or won't take the virus, the vaccine, and those people for us are the ones to be concerned about in terms of vulnerability. So the road from here to becoming endemic is always going to be bumpy. There's going to be nations that are actually going to be in an epidemic, and health services are going to be strained. No matter how we go do this, there will be people who die, and it's really trying to manage how many people die and how we can cope with that. The other thing to note when we're talking about this road to becoming endemic is that different countries will enter this endemic phase at different times. So if we think of Africa, they're going to be hugely impacted as to when they become endemic. So they will always be epidemic until their vaccines are good enough. And the virus will always continue as long as there's large places of an epidemic. So we do have to think about how we get vaccines to countries that can't have the vaccine. Now, I thought it's also good to think about what vaccine hesitancy is, because people use this term quite a lot. So vaccine hesitancy is not something new with COVID. It's been here for a long, long time. In fact, in 2019, the World Health Authority declared vaccine hesitancy as one of our top 10 global threats. Now, vaccine hesitancy is really complex. So we talk about people who don't vaccinate, but they are really a small group of people who don't vaccinate. The larger group of people are hesitant, and they have genuine reasons to be hesitant. So some people are hesitant because they have concerns about the virus, or they have concerns about the vaccine, and those are concerns that we need to alleviate or talk through. Other people are genuinely hesitant because of distrust. And if I think of minority groups who had bad experiences before, you can understand this distrust. And of course, there is this issue of health literacy and knowledge. So some people actually are working their minds through all the different bits of information that are coming to them and still trying to make up their mind. And like I said before, this actually is genuine voids in how much we know. So there is some bits of knowledge that we still need to get. When we talk about policy, policies expect that we see everything in the same way and we see benefit in the same way. But actually our values differ quite a lot when we look at different things that may affect hesitancy. And so for that reason, people are hesitant for different reasons. One of the most effective things in dealing with hesitancy is actually community partnerships, so talking to people at their local levels and talking about the hesitancy and working through that. I think I am on my last slide, which you'll be happy to know. I think I may have gone over time. So people are also talking a lot about mandatory vaccination, and I thought it would be good here to just summarize a little bit about what we mean when we talk about mandatory vaccination. We're not thinking about mandatory vaccination in Australia. That's quite different from vaccine passports, which is a different conversation. There's lots of reasons why mandatory vaccination may be a good thing. And there's also lots of reasons why it is not a good thing. So on both sides, there's lots of things that we need to think about and we need to balance. But whatever it is, when we make these decisions, we need to have a certain level of trust and conversations. It needs to be evidence-based, and we need to be hearing from lots of different people, and often people who don't think the same way as us. One of the things that's going to be really important for us is to make sure that we keep our governments accountable in terms of all of these vaccination discussions. So some of the things to think about is the compelling case for vaccination and the context, like for example, those boosters, who should be exempt, what would be the process for exemption, and then of course for each of us thinking about whether we're happy to wear the consequence of non-compliance. I think that is where I will end. Thank you so much for listening to me, and I'm sorry if I went over time.